Hello everybody. Today we are going to discuss about the decompensated cirrhosis and one of its most common complication, that is ascites, and we'll see how to manage this. So what is the pathophysiology behind decompensated cirrhosis? The transition from compensated asymptomatic cirrhosis to decompensated cirrhosis occurs at a rate of about 5% to 7% per year. Once the decompensation has occurred, cirrhosis becomes systemic disease with multi-organ dysfunction. At this stage, patient becomes highly susceptible to the bacterial infection because of the complex cirrhosis-associated immune dysfunction, which involves both innate and acquired immunity. In turn, patients with the bacterial infection are burdened by severe morbidity up to ACLF and high mortality. Because of this event, decompensation represents a prognostic watershed as median survival rate drops from the more than 12 years for compensated cirrhosis to the 2 years for the decompensated cirrhosis. For decades, the clinical manifestation of decompensated cirrhosis have been seen as a consequences of hemodynamic disturbance, the hyperdynamic circulatory syndrome ascribed to the peripheral arterial vasodilatation that mainly occurs into the splanchnic circulatory area. The extent of such a vasodilatation is to endanger effective volemia, ultimately leading to the peripheral organ hypoperfusion, and the kidney is being most commonly affected. Indeed, reduced effective volemia brings about the activation of vasoconstrictor and water and sodium retaining mechanisms such as renin, angiotensin, aldosterone, sympathetic nervous system, and the arginine vasopressin secretion. This explains some of the cardinal features of the decompensated cirrhosis, such as renal retention of the sodium and water, leading to ascites formation and HRS. Other manifestations attributable to the hemodynamic abnormalities include HPS, increased susceptibility to the shock, and the reduced cardiovascular responsiveness to physiological and pharmacological vasoconstrictor stimuli. Subsequent studies have highlighted the cardiac dysfunction due to CCM is also involved in the pathogenesis of effective hypovolemia. This occurs particularly in the most advanced stage of decompensation, when such an abnormality prevents the cardiac output from increasing enough to comply with the need of systemic circulation. Although molecular mechanisms are responsible for arterial vasodilatation, they consist of the enhanced endothelial production of vasodilating substance such as nitric oxide, carbon monoxide, prostacyclin, and endocannabinoids. This is likely caused by the systemic spread of the bacteria and bacterial products called as pathogen-associated molecular pattern as a result of abnormal bacterial transportation. Changes in the microbiome and increased intestinal permeability account for this phenomenon. Similar role is likely played by the other molecules such as danger-associated molecular pattern released by diseased liver because of the local inflammation and cell apoptosis and necrosis. Both PAM and DAM binds with the innate recognition of receptor of innate cell. Once activated, produce and release pro-inflammatory molecule along with reactive oxygen and nitrogen species. This cascade of events contribute to the development of circulatory dysfunction. Along with it, directly favors the development of multi-organ dysfunction and failure. Current strategies for the prophylaxis and treatment of decompensation and organ failure in the cirrhosis rely on the measures aimed to prevent or improve outcome of each complication. That is renal sodium retention leading to ascites formation, ammonia production in hepatic encephalopathy, effective hypovolemia after large volume paracentesis or during HRS, renal dysfunction induced by SBP, and intestinal dysbiosis or bacterial overgrowth in patients predisposed to develop infection. Now, how to manage this decompensated cirrhosis? So the first approach is the suppression of etiological factor, and the second approach is on the targeting key factors responsible for the pathogenesis of cirrhosis, decompensation, and progression. Now we'll see what are the recommendations. So in patient with the decompensated cirrhosis, the etiological factor should be removed, particularly alcohol consumption and hepatitis B, C virus infection, as this strategy is associated with decreased risk of decompensation and increased survival. Strategies based on targeting abnormalities in the gut-liver axis by antibiotic administration, improving disturbed systemic circulatory function, and reducing portal hypertension, like by adding beta blocker, have shown potential benefit to decrease cirrhosis progression in patients with the decompensated cirrhosis. Now we'll talk about the management of this most common complication of the cirrhosis, that is ascites. So ascites is the most common decompensation in the cirrhosis, as 5 to 10% of patients with compensated cirrhosis per year develop this complication. And why this complication is happening? It is because of the renal sodium retention due to activation of the RAS and sympathetic nervous system, which results into the positive fluid balance, ultimately leads to the extracellular fluid volume expansion. So, the reduced effective volume, secondary to the splanchnic arterial vasodilation, is the main determinant of this alteration, but renal function abnormalities induced by systemic inflammation. Now, uh, this is divided into uncomplicated cirrhosis and complicated. So, in uncomplicated cirrhosis, evaluation of the patient with ascites. How to evaluate this? So, cirrhosis is the most common cause of ascites in Western world, being responsible for 80% of the cases. Now, the malignancy, heart failure, tuberculosis, pancreatic disease, these are the other rare complications. So, for evaluation, we need to take history, physical examination, abdominal ultrasound, and lab assessment of liver and renal function, serum and urine electrolyte, as well as analysis of ascitic fluid. Now, for diagnosis of the ascites is graded from the 1 to 3 according to the amount of the fluid in the abdominal cavity. An ascites that recurs at least on 3 occasions within 12-month period, despite dietary sodium restriction and adequate diuretic dosage, is defined as recidivant. So, diagnostic paracentesis is indicated in all patients with new onset of grade 2 and 3 ascites and in those admitted to the hospital for any complication of cirrhosis. Manual and automated neutrophil count, total protein, albumin concentration, and culture should be sent and properly assessed. Now, if this neutrophil count is above 250, then it is spontaneous bacterial peritonitis. And if the total protein concentration is less than 1.5, then it is a risk factor for the SVP. So ascitic fluid culture requires the bedside inoculation of at least 10 ml of the blood, 10 ml into blood culture bottle to enhance its sensitivity. And our next job is to find serum ascites albumin gradient. Now, why this is important? Because if this SAG is more than 1.1, then it indicates the probable etiology of this ascites is portal hypertension. And other tests and if it is less than 1.1, then the probable etiology of the ascites is not related to portal hypertension. The other tests which are important is amylase cytology culture for mycobacteria, which is guided by clinical presentation. Now, ascitic cholesterol determination followed by cytology and chorioembryonic antigen determination in sample where cholesterol concentration exceeds 45 mg per dl appear to be cost-effective method for differential diagnosis between malignancy-related and non-malignancy-related ascites. Now, how to prognosticate this patient? So, the development of ascites in patients with cirrhosis is associated with the poor prognosis, and their 1 or 2 year mortality is about 40 to 50%. Thus, patients with the ascites should be considered for the referral for liver transplantation. Now, hyponatremia, low arterial pressure, GFR, and the low renal sodium excretion. These are the independent predictor of the mortality in cirrhosis with ascites. So, as these parameters are not included in childhood score, and only serum creatinine, which overestimates the GFR in cirrhosis, is included in the MELD score, which is the most commonly used prognostic score that can underestimate the mortality risk in patients with ascites. So the modification of the MELD score, such as MELD sodium and MELD ascites score, are only partially overcome this limitation. Thus, the patient with ascites may not receive the adequate priority in transplant list, and improved method to assess the prognosis in these patients are needed. So the prognostic score able to identify patient with the low MELD score have high risk of 12-month adverse outcome. So how to, if I want to explain how to prognosticate this patient on the basis of the MELD score. So if the patient, if he is dealing with the patient with the ascites, and if the MELD score is less than 80, then there is a high risk of 12-month adverse outcome. So the next, now we'll see what are the recommendations. So the diagnostic paracentesis is must in all patients with the new onset grade 2 and 3 ascites, and in those with the hospitalized for worsening of ascites or any complication of cirrhosis. So our next job is to to analyze the fluid properly. So what we will see in this, we'll see the proper neutrophil count, and we'll send the fluid for the culture to find out the possible etiology, like to exclude the bacterial peritonitis. And if the neutrophil count is above 250, then we need to consider the possibility of subacute bacterial peritonitis. Now, the next job is to find out ascitic total fluid concentration to find out the patient who are at high risk of developing SPP. Then, as I mentioned before, we should know the SAG ratio to find out the possible etiologies. Portal hypertension is there or not. Then cytology to differentiate between the malignancy and malignant ascites and non-malignant ascites. Since the development of the grade 2 and 3 ascites in patient with the cirrhosis is associated with the reduced survival, liver transplant should be considered as the potential treatment option. Now, how to manage this. So ascites is uncomplicated when it is not infected, it is refractory and associated with the HRS. So grade 1 and mild ascites. So no data on evolution of grade 1 ascites is available, nor it is known whether its treatment modifies its natural history. Now regarding grade 3 or moderate ascites. So patients who develop grade 2 ascites, they do not require hospitalization unless other complications are present. They have positive sodium balance, which can be corrected by reducing dietary sodium intake and increasing renal sodium excretion with diabetes. Although upright posture favors the renal sodium reabsorption and attenuate response to diuretic, there is no evidence that prolonged maintenance of supine position aids the treatment of the ascites. Now, how to grade this ascites? So, grade 1 is mild ascites. It is only detectable by ultrasound examination. Grade 2 is moderate ascites. It is manifested by the moderate symmetrical distension. And grade 3 is the large and the gross ascites. It provokes marked abdominal distension. Now we'll see what are the recommendations. A moderate restriction of the sodium intake is recommended in patient with the moderate and uncomplicated ascites. That means they should take the sodium which is equal to the 4.6 to 6.9 gram of the salt. This is generally equivalent to the no added salt diet with avoidance of the prepared meals. Adequate nutritional education of the patient on how to manage the dietary sodium is also recommended. Diet with a very low sodium concentration should be avoided as they favor diuretic-induced complication and can endanger patient's nutritional status. Prolonged bed rest cannot be recommended because there is insufficient evidence that is beneficial in the treatment of the ascites. Now, regarding diuretic, patient with the first episode of the grade 2 ascites should receive antimineralocorticoid drug alone, starting at 100 mg per day with stepwise increase every 72 hours to maximum of 400 mg per day if there is no response to the all overdose. In patients who do not respond to antimineralocorticoid as defined by body weight reduction of less than 2 gram per week, and in patients who develop hyperkalemia, furosemide should be added at increasing stepwise dose from 40 mg per day to maximum of 160 mg per day. Patient with the long-standing and the recurrent ascites should be treated with combination of anti-mineralocorticoid drugs and furosemide, the dose of which should be increased sequentially according to the response. Torsemide can be given in patients exhibiting weak response to the furosemide. So during diuretic treatment, the maximum weight loss of 0.5 kg per day in patient without edema and 1 kg per day in patient with edema is recommended. Once ascites has largely resolved, the dose of diuretic should be reduced to the lowest effective dose. During first week of the treatment, patients should undergo frequent clinical and biochemical monitoring, particularly on first presentation. In patients presenting with the GI hemorrhage, renal impairment, hepatic encephalopathy, hyponatremia, or alteration in serum potassium concentration, these abnormalities should be corrected before starting diuretic therapy. When this patient cautious initiation of diuretic therapy, the frequent clinical and biochemical assessment should be performed. Diuretic therapy is generally not recommended in patients with persistent overt hepatic encephalopathy. Diuretic therapy should be discontinued if severe hyponatremia, AKI, worsening hepatic encephalopathy, or incapacitated muscle cramps develop. Furosemide should be stopped if severe hypokalemia, and anti-mineralocorticoid should be stopped if severe hyperkalemia occurs. Albumin infusion and baclofen administration, that is 10 mg per day, with weekly increase of 10 mg per day up to 30 mg per day, are recommended in patients with muscle cramps. Now, regarding grade 3 or large ascites, the treatment of choice for management of the patient with grade 3 ascites is represented by large volume paracentesis. Paracentesis should be performed under strict sterile conditioning using disposable sterile material. The procedure is associated with very low risk of local complication, particularly bleeding, even patient with INR of more than 1.5 and platelet count of less than 50,000. Thus, there are no data supporting the prophylactic use of fresh frozen plasma of full platelet, even though these are employed in many centers when prothrombin activity is below 40% and platelet count are below 40,000. Large volume paracentesis should be avoided in the presence of DIC. Now, contraindication of the paracentesis. That is uncooperative patient, abdominal skin infection at proposed puncture site, pregnancy, severe coagulopathy, and severe bowel distension. So the removal of the large volume of ascitic fluid is generally associated with further reduction of effective blood volume, and the condition is known as post-paracentesis circulatory dysfunction. The clinical manifestation of the post-paracentesis circulatory dysfunction are renal failure, dilutional hyponatremia, hepatic encephalopathy, and decreased survival. So plasma volume expansion should be performed at the completion of large volume paracentesis to prevent this complication. Artificial plasma expanders such as Dextran 70 and the polygalin saline solution and albumin when less than 5 liters of ascites are removed. So we'll see what are the recovery. Large volume paracentesis is the first line therapy in patients with large ascites, which should be completely removed in the single session. Large volume paracentesis should be followed with the plasma volume expansion. Those patients with the large volume paracentesis of greater than 5 liters of ascites, then plasma volume expansion should be performed by albumin. But if the ascitic volume is less than 5 liters, then the complication of the circulatory dysfunction is low, but still it is advisable to administer albumin because of concern about the use of alternative plasma expander. After large volume paracentesis, patient should receive the minimum dose of diuretic necessary to prevent reaccumulation of the ascites. When needed, LVP should be performed in patient with AKI or SP. Now, what are the drugs which are contraindicated with the ascites? NSAID should not be used in patients with ascites because of the high risk of development of sodium retention, hyponatremia, and AKI. AC inhibitor, ARB, and alpha adrenergic receptor blocker should not be used in patients with ascites because of the increased risk of the renal impairment. The use of aminoglycoside is discouraged as they are associated with increased risk of ACAM, and their use should be reserved for patients with severe bacterial infection that cannot be treated with antibiotics. The patient with ascites and preserved renal function. The use of contrast media does not appear to be associated with increased risk of renal impairment, and there are insufficient data in patients with renal failure. Nevertheless, the cautious use of contrast media and the use of preventive measures for renal impairment are recommended. Now, how to manage refractory ascites? According to the criteria of the International Ascitic Club, refractory ascites is defined as ascites that cannot be mobilized or early recurrence of which cannot be satisfactorily prevented by medical therapy. Refractoriness of the ascites is associated with poor prognosis with median survival of about 6 months. Therefore, if patient with the refractory ascites has not been considered for liver transplant, he or she should be immediately referred to the liver transplant center. The diagnosis of refractory ascites relies on the assessment of the response of the ascites to diuretic therapy and salt restriction. Such an evaluation should be done in stable patients without associated complications such as bleeding, infection, and after ascertain patient compliance to the treatment. Patient with the refractory ascites should be evaluated for liver transplant. Now, what is this refractory ascites? Now, diuretic resistant ascites. Ascites that cannot be mobilized or early recurrence of which cannot be prevented because of lack of response to sodium restriction and diuretic treatment. Diuretic intractable ascites. Ascites that cannot be mobilized or early recurrence of which cannot be prevented because of development of diuretic induced complications that preclude the use of effective diuretic usage. Now, regarding treatment duration, patient must be on intensive diuretic therapy, that is spironolactone 400 mg per day and furosemide 160 mg per day for at least 1 week and on salt restricted diet of less than 90 mg. Lack of response, that is mean weight loss of less than 0.0 kg over 4 days and urine sodium output of less than sodium intake. Early ascites recurrence, reappearance of grade 2 and 3 ascites within 4 weeks of initial mobilization. Now, diuretic-induced complication. Diuretic-induced hepatic encephalopathy is development of encephalopathy in the absence of any other precipitant factor. Diuretic-induced renal impairment is increasing serum creatinine by 100% to value of more than 2 mg per dl in patient with ascites responding to treatment. Diuretic-induced hyponatremia is defined as decreased serum sodium by more than 10 mmol per liter to serum sodium of less than 125. Diuretic-induced hypo or hyperkalemia is defined as change in serum potassium to less than 3 or more than 6 despite appropriate measures. Now, regarding management of refractory ascites, large volume paracentesis. There is general agreement that LVP is generally safe and effective treatment of refractory ascites, and it should be associated with albumin administration. Diuretics in patient with refractory ascites. Once refractoriness of ascites has been ascertained, diuretic should be discontinued. Only when serum sodium excretion on diuresis is exceed 30 mmol per day, maintenance of diuretic can be considered. Now, regarding the use of non-selective beta blocker, controversial issue on the use of NSC, non-selective beta blocker in patients with ascites, particularly those with refractory ascites who develop insection, particularly those, but we'll have a brief discussion of this in upcoming sections. Now, regarding TIPS therapy, the transjugular intrahepatic portosystemic shunt decompress the portal system by shunting intrahepatic portal branch into hepatic. Its insertion accentuates the peripheral arterial vasodilation in short term. However, within 4 to 6 weeks, its result is improvement in ineffective hypovolemia, renal function, ultimately leading to increase in renal sodium excretion. So TIPS induce the natriuresis can be delayed by advanced age and reduce TIPS GFR prevented by intrinsic kidney disease. So TIPS also may also exert beneficial effect on nitrogen balance, nutrition, and quality of life. Major complication of TIPS is hepatic encephalopathy. Now we'll see what are the medical therapies aimed at improving circulatory and renal dysfunction have been proposed. Alpha-adrenergic agonist, that is midodrine, has been shown to improve systemic and renal hemodynamics in patients with cirrhosis and uncomplicated ascites. A small RCT was conducted comparing the addition of midodrine to diuretic therapy with diuretic treatment alone with refractory ascites for 6 months. And they show transient beneficial effect on control of ascites at 3 months. The use of terlipressin, which is an analog of vasopressin, at predominant vasoconstrictor effect in splanchnic valve circulatory area in patients with refractory ascites has only been assessed in acute studies. So this terlipressin administration in the dose of 1 to 2 mg only increase renal sodium excretion when associated with exogenous atrial natriuretic factor. The another study in which they have used 2 mg of terlipressin lead to increased GFR, renal plasma flow, and renal sodium. But in this study, only 8 patients with refractory ascites were used. When prolonged treatment with terlipressin may lead to clinically relevant improvement of renal function and sodium excretion in refractory ascites patient is known. Now, regarding the alpha adrenoreceptor agonist, that is clonidine, it is a sympatholytic drug which suppresses RAS activity and improves response to diuresis in patients with cirrhosis and ascites. It is shown that if we are used clonidine with the diuretics for 3 months, so it lead to the overall response to diuretics in 60% of cases. And this effect was associated with significant reduction in the RAS and sympathetic nervous activity. Now our last resort of the therapy is alpha. Automated low-flow ascitic pump system consisting of subcutaneously implanted battery-powered programmable pump. It is connected to the catheter that transfers ascites from peritoneal cavity to the bladder, from which it is eliminated with urine. This device has internal sensor that monitor pump function. So there are two multi-center safety and efficacy studies were conducted in which they showed that alpha pump is ensured significant reduction of number and volume of paracentesis in patients with advanced cirrhosis and refractory ascites. An alpha pump had no effect on survival and was associated with significant higher incidence of serious adverse effect, mainly represented by AK. So we'll see what are the recommendations. Repeated large volume paracentesis plus albumin is first line treatment for refractory ascites. Diuretic should be discontinued in patients with refractory ascites who do not excrete more than 30 mol per day of sodium under diuretic treatment. Although controversial data exists on use of non-selective beta blocker, caution should be exercised in case of severe and refractory ascites. High dose of non-selective beta blocker should be avoided. That is propranolol more than 80 mg per day. The use of carvedilol cannot be recommended at present. Patients with the refractory and recurrent ascites or those for whom paracentesis is ineffective should be evaluated for TIPS insertion. TIPS insertion is recommended in patients with recurrent ascites as it improves survival and in patients with refractory ascites as it improves control of the ascites. The use of small diameter PTE covered stent in patients is recommended to reduce the risk of TIPS dysfunction and hepatic encephalopathy. So diuretics and salt restriction should be continued after TIPS insertion up to resolution of the ascites. Careful selection of the patient for elective TIPS insertion is crucial as is experience of the center performing this procedure. TIPS is not recommended in patients with serum bilirubin more than 3, platelet count lower than 75, current hepatic encephalopathy of grade more than or equal to 2, chronic hepatic encephalopathy, concomitant active infection, progressive renal failure, severe systolic diastolic dysfunction, and pulmonary hypertension. At present, the addition of clonidine and midodrine to diuretic treatment cannot be recommended. Alpha pump implantation in patients with the refractory ascites not amenable to TIPS insertion is suggested in experienced center. However, close patient monitoring is warranted because of the high risk of adverse event, including renal dysfunction and technical difficulties. Thank you, guys.